Okay, this is the second voiceover in Chapter 14 on blood. We're going to pick up where we left off, which was when we wrapped up the erythrocytes, or red cells. We're going to talk in this voiceover about white cells and platelets and plasma. So as you recall from the previous voiceover, there are 5 different kinds of leukocytes, or white blood cells, and you see those listed here. The 3 with the yellow or the green asterisk next to it denotes that these 3 types of leukocytes are referred to as granulocytes or granular leukocytes. Remember from the previous voiceover, these possess stained granules in their cytoplasm, so they're very easy to distinguish between those that have the granules and the 2 listed here, number 4 and 5, the monocytes and lymphocytes that lack the granules. Remember, the prefix A here means without stained granules in the cytoplasm. So by looking through a microscope at a white cell, you can pretty easily differentiate the granular leukocytes or granulocytes from the agranulocytes or agranular leukocytes. These 5 types of white cells, remember, originate with that hematopoietic stem cell, which then differentiates into either a myeloid or a lymphoid stem cell in the presence of growth factors. And in the case of white cells, we're specifically mentioning 2 types of growth factors, which are actually hormones. And you see those listed here, the interleukins and colony stimulating factors, or CSFs. They help to regulate the differentiation of either the myeloid or the lymphoid stem cell into one of the 5 types of white blood cells. Also notice I've indicated here the white cell count, between 3,500 and 10,500 white cells per cubic, pure microliter or cubic millimeter. It's quite a wide range, isn't it? But that's nonetheless the range of normalcy in an individual. The lifespan, as we'll talk more about, can vary considerably from a few weeks to several years, depending upon the type of white cell. And under the microscope, you would notice, and will notice, that these are typically 2 or even 3 times larger than the average red cell. So they're typically quite a bit bigger. Of course, don't forget they're going to have a nucleus, and some of these white cells are going to have stained granules and others will not. Here's that flowchart I was talking about, our differentiation figure. This is on page 533 of your textbook. And again, I've circled the 5 types of leukocytes. Here again are the 3 granulocyte types, and here are the 2 agranular leukocytes. So you can always come back and refer to this diagram to get a sense of which type of stem cell, specifically myeloid or lymphoid, is going to give rise to which type of white cell. It's actually pretty easy if you just think about lymphoid stem cells give rise to lymphocytes. We'll talk more about the 2 types in a few minutes. And then the myeloid stem cell, you'll notice, will differentiate into the other 3 types, or actually other 4 types of leukocytes, the 3 granular leukocytes, as well as this other type of agranulocyte, the monocytes. You'll also notice here that the myeloid stem cell also gives rise to red cells as well as platelets. So it produces the vast majority of formed elements, doesn't it, in the bloodstream. So here's the first of our 5 white cells, the neutrophils. This particular type of white cell is responsible for over 50% of circulating white cells, so 54 to 62% on average of the white cells in your bloodstream as we speak would be of this type. Again, note that it's probably 2.5 times the size of your typical red cell, which we see here in this photograph. All of these guys are red blood cells. And pay a particular attention to two things here. First, the presence of stained granules in the cytoplasm, these purple dots. And the other thing that's quite interesting about the neutrophil relates to its nucleus. This is a single nucleus, quite an interesting shape, isn't it? It has multi-lobed morphology to it, which is often why some books will refer to this as a polymorphonuclear leukocyte, which literally means many-shaped nucleus. This particular white blood cell is one of the first to arrive at an injury site, especially when you have an infection, where they will phagocytize bacteria, fungi, even viruses they're able to phagocytize. So they are pretty important in fighting infection. Our second granular leukocyte is the eosinophil, which contains a nucleus that is bilobed, which is pretty easy to see. It kind of looks like a kidney bean in some respects. These particular white cells are often very common during allergic reactions. Their numbers increase during an allergic reaction. So if you're sensitive to ragweed or pet dander of some sort, in the spring of the year, for example, I suffer from hay fever oftentimes, or even in the fall, or if I'm mowing the grass. And if I were to monitor my bloodstream and the white cell numbers and different types of white cells in my body at those times of the year, in the spring and fall, I would see an elevated eosinophil count, because again, my body's responding to the presence of those allergens. These make up only about 1 to 3% of circulating white cells, so they're not nearly as abundant as the. And our last granulocyte is the basophil. This is the least common of the various types of white cells. Less than 1% of circulating white cells are basophils. That's not to say they're not very important, however, because as you note from the slide, this particular white cell produces two different important chemicals. One is called histamine and the other is called heparin. Let's talk a little bit about histamine first. You probably have all taken at some point in your life an antihistamine. When you have a cold, when you have hay fever, runny nose, watery eyes, is something we don't enjoy. So we often will take an antihistamine to reduce the production of mucus and various secretions. So antihistamines try to reduce secretion of fluids. A histamine, in this case, does just the opposite. It promotes fluid formation. And we'll be talking in a few moments about the inflammatory response and how this can actually be beneficial when we try to wall off an invader, like a bacterium during an infection, for example. And so basophils actually produce the histamine, and this can, in the short term, result in increased fluid production, which can aid in actually the inflammatory reaction. Heparin, we talked a little bit about in the previous voiceover. We said that this particular chemical prevents blood from clotting. This, remember, was lining the inner surface of that capillary tube that we spun down when we went to look at the percent of packed cells or the amount of plasma, right? So heparin is a chemical produced by basophils which actually promotes inflammation. You may wonder, well, why would you want to promote inflammation? Well, inflammation, which again we'll get into, is telling us that our body is fighting off some sort of an infection or microorganism that's trying to cause problems. So more on that a little bit later. The first of our two agranular leukocytes here is the monocyte, the biggest of the white cells. You can tell that this monocyte again is probably 3 or maybe even 4 times larger than the average red cell. You can see the bilobed nucleus. So in that sense, it doesn't look a whole lot dissimilar to some of the earlier white cells that we looked at. But note what you don't have in the cytoplasm. You don't have granules, right? This particular white cell is really, really important. It's highly phagocytic. And when monocytes leave the bloodstream, they're then referred to as macrophages. So don't let that throw you. This term macrophage is not a sixth type of white cell. It is a monocyte that has left the bloodstream, got on into the tissues, where it's presumably going to phagocytize bacteria, for example, that might have been introduced in a cut or wound. And so they're really, really important in helping to basically knock out bacteria, virally infected cells, that kind of thing. They make up about 3 to 9% of circulating white cells and actually can live for months or several weeks. So they have a much longer life expectancy than the average white cell. Our last type of leukocyte, the lymphocyte, is just a little bit bigger than the average red cell. Notice again the absence of granules in the cytoplasm, but what I look for if I were to try to identify a lymphocyte on a slide, on a stained blood sample, is I'm looking for, first of all, a cell about the same size as a red cell, and then I'm also looking here for a fairly round nucleus that takes up the majority of the cytoplasm. That's another dead giveaway that you're looking at a lymphocyte. In later chapters, in the last chapter of the semester, we'll be talking more about these lymphocytes, and specifically we'll be discussing the two major types here, the T and B cells, or T and B lymphocytes. Maybe you've heard of them. We'll talk more about them. They're extremely important in the immune response. Well, we just mentioned a few moments ago about how when a monocyte leaves the bloodstream, it's then defined as a macrophage. And so here's that very process taking place. It's called diaphoresis. And here we've got a leukocyte. We're not really identifying it as a monocyte, but let's pretend it is. Other white cells can leave the bloodstream as well and undergo diaphoresis, but let's just pretend it's a monocyte. And so here it is squeezing between the endothelial cells that make up the wall of this blood capillary. We said earlier in the respiratory chapter that it's at the capillaries where we have gas exchange taking place, right? And so we have just this single layer of cells, the simple squamous cells you see here. Here's one, here's another. And this leukocyte is squeezing in between the cell membranes, going out into the tissues, where presumably there is, say, some bacteria that need to be phagocytized and killed. White cells can only leave the bloodstream at capillary beds. They can't get out of veins or arteries because you have many more layers of tissue beyond the simple squamous and would just prohibit them from getting out of the bloodstream. Here they can do so quite easily. Well, we talked about the inflammatory response a few moments ago with respect to basophils, for example, producing histamine. And so this chemical is, again, promoting fluid secretion, which in this case is actually helping to wall off potentially introduced bacteria. So let's pretend we have a splinter. We've all suffered from splinters. It's obviously, in this case, penetrated the epidermis of the skin and gone down into the dermis, and has also ruptured some of the capillaries here in the dermal papillae, and as a result, blood begins to leak out onto the surface of the skin. Doesn't have to be too deep, does it? But you've introduced into the epidermis and into the bloodstream bacteria more than likely. So in this second right-hand diagram, we see the bacteria shown here as these little green sort of oval circular structures. And so we've got the basophils producing the histamine, causing dilation of blood vessels as a result of the influx of fluids. And also we have something called positive chemotaxis taking place. Because it turns out that the tissue damage here results in the tissue releasing various chemicals which actually cause white cells to be drawn to that injury site. In the same way, for example, if you're going out into the ocean and you want to catch a shark, the classic way to catch sharks in the ocean is to chum. So they take buckets of blood and cut up fish, and they dump that off the back of the boat as the boat's trolling along, and the blood is picked up by the very sensitive olfactory sense organs of the shark. The shark is drawn to the back of the boat, the blood trail basically, and that's how you catch a shark. Throw out a hook with a large fish on it, and your increased chances of catching that shark. Well, think of the blood that contains the cut up shark, or cut up fish, I should say. Here we've got chemicals being given off by the damaged tissue, and what's drawing the sharks in, if you will, think of the white cells as the sharks, they're being drawn in by the release of these chemicals by the damaged tissue, and they're going to be phagocytizing the bacteria. The neutrophils and the macrophages specifically love to phagocytize these bacteria. So positive meaning coming toward the chemical. Chemo refers to chemical. Oftentimes, different illnesses are diagnosed based upon blood that's taken from the patient and analyzed. And one thing that they'll often do is they will compare the percentages of these 5 types of white cells to normal percentage ranges. It's referred to as a differential white cell count. So if you ever get a blood draw and you get the report back, look through that and you'll see the expected percentages of neutrophils, basophils, eosinophils, monocytes, lymphocytes, and then you'll see your percentages too. And so somebody, for example, who's suffering from mononucleosis, suspected anyway of suffering from that, if they get a blood draw, the physician would likely see an elevated lymphocyte count. Or if the person's been to the Amazon for a month and comes back with a high fever, periodic fever, and just not feeling very great, and they do a blood draw, they might discover an elevated monocyte count or percentage. And having done some questioning of the individual, like where have you been the last few months, and they tell them they've been in the tropics, that could be a clue to the physician that that individual may have been bitten by a mosquito that carries a particular protozoan that causes malaria. You've all heard of AIDS. AIDS we associate with a reduction in the immune response, and that's because when the virus gets into a host cell, that host cell is a T lymphocyte, a very important cell in the immune reaction. And so AIDS really reduces the number of viable helper T cells, and as a result, somebody with later stage AIDS cannot fight off simple infections. Opportunistic infections can kill somebody with late stage AIDS because of these helper T cells not working the way they're supposed to. There's just too few of them. This is not a table you need to memorize, but I just wanted to point out the fact that different kinds of illnesses and diseases can result in elevated counts of specific types of white cells. In your textbook, there is an interesting clinical application box there on page 542 that I want you to read. It talks about leukemia. I think we've all heard of that a little bit. Maybe you know somebody who's had leukemia. And they discuss the 2 different types, myeloid and lymphoid. And you might have heard those terms before because remember, those are the 2 types of stem cells that differentiate from that initial precursor hematopoietic stem cell. Again, go back in page 533, check out figure 14.4. So somebody with myeloid leukemia is producing an abnormal number of eosinophils, basophils, or neutrophils, or monocytes. Those are the 4 types of white cells that are formed as a result of myeloid stem cells differentiating. Only these white cells that are produced not only are high in number, but they're not functional. They don't work the way they're supposed to. Lymphoid leukemia is specifically talking about lymphocyte cells that are being impacted, increased numbers, and the fact that they don't function the way they're supposed to. So they'll talk about those two types of leukemia in that clinical application box, and they'll also describe the difference between what is referred to as chronic versus acute. So I'm not going to spend any more time talking about that, but do check out that clinical application. Okay, there's that flowchart that I was referring to a few moments ago. Next, about thrombocytes or platelets, our third formed element. Remember, there are three types of formed elements: red cells or erythrocytes, white cells or leukocytes, and thrombocytes or platelets. These small little cell fragments, they're not even considered complete cells. Little small fragments of cells are produced within our red bone marrow as a result of those myeloid stem cells differentiating into what are called megakaryocytes. These are big, big cells. Again, go back, check out that flow chart. I think the next slide is going to actually show this. And it's from these huge megakaryocytes that these small little bitty cell fragments called thrombocytes form. It's just sort of ironic, I think, that you get these huge megakaryocytes forming into these tiny little bitty formed elements. And this process of platelet formation from the megakaryocytes occurs in the presence of a hormone, which I've listed here in yellow, called thrombopoietin, produced by our liver and our kidney. Now you might remember in the previous voiceover we talked about erythropoietin produced by the liver and kidney in response to EPO or erythropoietin. Don't get those mixed up. Thrombopoietin, thrombo referring to thrombocyte, is a hormone produced by these same organs that promotes the differentiation of the big megakaryocytes into the functional thrombocytes. And there's the diagram that I was referring to, so check that out. They are very, very small, as we said. And some of the earlier photographs, I think I had placed some arrows to kind of draw your eye to some of these small little platelets. This photograph, which is a little more difficult to see, has the same designation. The arrows are pointing to these small little specks here in the photograph. Some people might have not even noticed that they were there if you didn't kind of look for them. So these are really, really tiny cells compared to the larger red cells or the really larger. They live a little over a week, so they're not around a whole lot. Their count between 150,000 to 350,000 cells per microliter. So yes, they're more abundant than white cells, but they're not nearly abundant as red cells are. And one really interesting property of platelets is their ability to stick to surfaces that have been damaged. Maybe a cut or a wound or build up a plaque within a blood vessel can cause these little cell fragments to stick to the broken, exposed collagen of various tissue surfaces. Another interesting thing that they do in addition to sticking to surfaces, broken surfaces, damaged surfaces, is the fact that when they encounter, let's say, a damaged blood vessel that's been torn by a sliver or a more significant injury, they will release a chemical called serotonin. And the effect of serotonin here is pretty profound. It will cause the smooth muscle that's lining the walls of arteries and veins and arterioles and venules to contract. Now, what benefit do you think that has in terms of blood loss? Well, if you take the lumen of a blood vessel and you restrict it by contracting the smooth muscle, that's going to reduce the blood flow through that blood vessel and thus reduce blood loss. So yes, they plug damaged blood vessels, platelets do, but they also promote the contraction of smooth muscle which in turn helps to reduce blood loss. So here we see a really nice table that summarizes the three types of formed elements, describes them, gives you the cell counts, the appropriate percentages, and their overall functions. So this is just a really great table to spend some time and review. The other component of blood, in addition to the formed elements, remember, is the plasma. When we spun that blood sample down earlier in the centrifuge, the upper 55% of that heparinized capillary tube was made of this straw-colored plasma. So this is the matrix, remember, of the connective tissue, the blood. It's called plasma. And of that 55% of the blood, notice that 92% of that is good old water, H2O, followed by what are called plasma proteins. So between the water of plasma and the plasma proteins of plasma, there's 99% of plasma, meaning, of course, that the remaining 1% is going to be composed of things called electrolytes, which are charged ions. We've talked a lot about calcium and the role it plays in muscle contraction. We're going to talk more about its role in blood coagulation in the next voiceover. Sodium, potassium, these are all examples of electrolytes. Then we have various waste products of the blood that we'll get into perhaps a little bit later, or certainly in another subsequent chapter. Various hormones that we've talked already about, actually. Colony stimulating factors, erythropoietin, interleukins, and gases, CO2 and oxygen being the most abundant and common gases, but even nitrogen gas can be included here in plasma. Not that we have a whole lot of that, though. Focus on the second most abundant constituent of plasma, which are the plasma proteins. And I'm going to just mention actually three major types of plasma proteins, the first of which is called albumin, making up the majority, 60% of circulating plasma proteins here is albumin. Originating in the liver, albumin helps to affect the osmotic pressure in the blood. Now, if you think back, we talked about earlier in the semester when we increased the solute concentration, what happened to the amount of water within the cell. Remember where water always moves from a region of higher water concentration to lower water concentration. Another way of saying that is movement of water from a lower solute to a higher solute, right? So let's think of albumin here as a solute, one of the more important solutes in the bloodstream. How could we cause more water to move from the tissues into the blood? Well, one way to do that is to increase the albumin concentration, because water is always going to move toward a higher solute. So if we increase albumin concentration and more water moves into the blood from the surrounding tissues until we reach an equilibrium, what effect will that have on blood pressure? Well, it's going to increase it because there's more water. There's a higher concentration of water in the plasma. We could also reduce blood pressure potentially by lowering albumin levels, which would then not have as much water moving in from the surrounding tissues. So this can be a really important factor that can influence things like blood pressure. And you'll be talking more about electrolyte, fluid balance in A&P 2. So you're going to hear more about albumin coming up next semester. The second most abundant plasma protein are referred to as globulins. And we're really not going to spend any time talking about alpha or beta globulins. These have a more important role to play in the digestive system. And that's where we talk about the transport of lipids within the digestive tract or from the digestive tract. And when you get into the nutrition chapter next semester, you'll talk about these fat-soluble globulin molecules. So we're not going to really talk much about them right now in the blood chapter, but I do want to talk about this third globulin called the gamma globulins. This is a fancy name for antibodies, which we'll be spending a lot of time talking about at the end of the semester when we get into the lymphatic system. But there's been a lot of recent material in the news talking about what would happen if we took some of the antibodies present in patients who have had COVID-19. Because when somebody gets COVID-19 or any sort of virus, your body responds to those antigens, that's what the virus would be, by producing antibodies against the antigen. And so again, somebody who's had COVID-19 has in their bloodstream antibodies to COVID-19. And there's been, again, a lot of talk about, well, could we take some of those antibodies from somebody who's gotten better from having that infection and give those antibodies to somebody who's not yet had COVID-19 or perhaps has an increased risk of getting it? We'd be protecting them potentially from the effects of the virus. So it's quite interesting. So more on antibodies coming up in a couple of weeks. And then the protein I want to talk a little bit about is called fibrinogen. It's certainly not a super abundant protein. Only about 4% of plasma proteins are of this type, but it plays a really critical role in blood clotting or blood coagulation. And again, we'll get into that coming up in the next voiceover. I do want to draw your attention to this term, however, fibrinogen, and have you note the suffix here, O-G-E-N. What this means is inactive form of the protein, which is the fibrin. Fibrin is the protein. And we'll talk about the role that this important protein plays in helping to prevent blood from being leaked out of you when you get a bad injury, a really, really bad cut. So your liver produces fibrinogen. It's circulating in your blood plasma as we speak. And if you get a significant wound or damage to tissues, that inactive fibrinogen is converted into fibrin, and that fibrin is going to play a really, really important role in helping contain the blood. It's going to help the blood clot. So more on that coming up in the